Good afternoon, everyone, or good morning, depending on where you might be in the country. My name is Tina Nelson, and I welcome you to our webinar this afternoon. Today, we are going to talk with a couple of ABMS Portfolio Program sponsors, and I'm really excited to get us to that. Again, I just want to thank you for taking the time to join us today. I want to wish everyone a happy Pride Month. And Spencer, we can go to the next slide, please. Just want to take a moment to acknowledge the world we live in. Next slide, please, Spencer. So just a little bit about what we're going to talk about today, just to kind of make sure everybody knows where we're going. The first thing we're going to do, I'm going to give you guys just a little bit of an overview about the portfolio program. I recognize that some of you may know a little bit about the portfolio program. I've actually spoken with a few of the people who registered for the webinar today, so that was pretty exciting to see. And then we will, like I said, hear from two portfolio program sponsors, one from the American Medical Association, the other the American Lung Association. And then really think about just kind of while we're listening to the sponsors today and while we're having conversation, thinking about what they have done and what they're doing with regard to implementing this program in their organizations and what that might look like or how that might work within your organization. Next slide, please. All right, so just a little bit about the portfolio program, and let me pause just for a moment to make sure I introduce myself. Again, my name is Tina Nelson. I have been with the portfolio program at the ABMS for just about 8 years now. It'll be 8 years next month, actually. However, I've been part of the portfolio program itself for much longer than that. Prior to coming to the ABMS, I was the portfolio program manager at the University of Wisconsin and worked with a couple of physician colleagues there to really plan, design, and implement that program. And I really, really believe in this program. I love this program so much that when it was opening up and coming to the ABMS, I was all about that. And I have been here ever since and loving it. So a little bit about kind of where the portfolio program came from, just so you guys know that how it sort of has evolved over the years. Back in 2008, maybe even a little bit before then, people in the continuing medical education space were really starting to reach out to the ABMS member boards because they were putting together education that was meeting performance improvement CME or continuing medical education requirements. And at that time, I was one of those people, and it was difficult to kind of navigate this space. We really wanted to help our providers. We knew they were working on quality improvement work. We knew we were designing and implementing performance improvement work, and it was meeting these criteria. So how could we talk to the member boards in a way that would allow us to not have 24 different applications for 24 different member boards and try to meet 24 different sets of requirements? And Mayo Clinic, the American Board of Internal Medicine, Family Medicine, and Pediatrics really came together and kind of put together this pilot idea of a portfolio program, meaning instead of an organization going to an individual member board and receiving credit or receiving approval for an individual project, the organization itself or the program itself is approved for how they design and implement and manage different quality or performance improvement activities. And then by way of meeting certain sets of requirements that multiple member boards have agreed to through this portfolio program, the organization only has to apply as a program rather than each time we have a new project that's coming through. So that was sort of how the portfolio program came to be. And several different organizations and several different member boards realized that this was, a really good way to be able to reach the diplomates that are working in the field. They're on the front lines. They're actually the clinicians that are seeing the patients, and they're just by way of what they're doing on a daily basis, we know they're engaged in this work. So it's been really great to be able to be part of an organization and a program that has helped really put a framework around what these people are doing on a daily basis and be able to offer them credit in a way that they weren't able to do that before. So they don't have to, go online and try to find an activity that meets their requirements so that they can fulfill their requirements. Instead, it's something that they're already doing. It's with their patients, their clinician, their clinical teams. It's in their space, so it's much more relevant, and that's a beautiful thing to be able to be part of. So in terms of the organization, the portfolio program, because a sponsor organization is able to say we're able to offer credit for these types of programs or this type of work or engagement in these types of QI coaching or training, for example. For them to be able to say that really helps to engage the providers. It gives them an incentive to participate if they're not already doing so. And again, it makes it much more relevant. And the portfolio program is in a place now where we're working with 18 different member boards. We're able to help provider organizations, sponsor organizations, offer credit to physicians and medical specialists within their organization or members who may be interacting with education that you might be putting together, and also some residents. And we have an agreement with the NCCPA such that PAs are also able to be submitted through this program and receive credit. So it's really looking at the care team, and we're starting to kind of engage in conversations that maybe will be able to benefit some additional members of the care team. Fingers crossed. Next slide, please. All right, so this is why you guys are here. I want to introduce you to some folks. Before I get to the sponsors, however, I want to pause for just a moment and acknowledge my colleagues that have helped put this webinar together. Spencer Walter is my colleague and my peer within the portfolio program itself. He's been at the ABMS for 3.5 years. There's Spencer, and he is. I just saw Maverick, right? The Top Gun movie. And I think we are that for each other. So this is Spencer, and you may have already spoken with him. I thank you for all you do, my friend. Another person I want to acknowledge is Sylvia McGreal, and she doesn't know that I'm doing that, but it would be really difficult to look at anything at the ABMS about the portfolio program, whether it be the website or these slides or any handouts that we have, the resources I'm going to send you after this call. It would be really difficult for you to find something that Sylvia hasn't touched. And she is in Marcom, and she is brilliant and wonderful. And aside from the portfolio program team, she is the person who knows the most about this program at the ABMS. So thank you to Sylvia. All right, so now I would like to introduce Dr. Marie Brown and Miss Jill Heinz-Nesvold from the American Lung Association. Dr. Marie Brown is from the AMA. And let me just pop over here. So Marie is the Director of Practice Redesign and the past governor, very importantly, of the Illinois chapter for the American College of Physicians. And Jill is the National Senior Director, Health Systems Improvement and Indoor Air Quality at the American Lung Association. And while these ladies talk with us today, share with you this afternoon, think about a few things. Think about how they have implemented or are still implementing even the portfolio program requirements into some of the different work that they're doing, the education that they're providing within their organizations. One of the things that I really have found over the last decade or so about this program is that you really truly can tailor it and implement it in your program in such a way that it meets the needs of your organization and the people that you serve. So just think about the different ways that the AMA and the American Lung Association have done that as these ladies take us forward. And with that, I will hand it over to Dr. Marie Brown. And next slide, please, Spencer.
Great. Can you hear me? Thumbs up, Tina. Thank you so much. And thank you for taking the time. Hopefully you're sitting down having lunch or a cup of coffee. I have 6 slides to share with you, and I'm very excited to share that a little bit about my background. I was in practice for 30 years as a general internist and geriatrician here in Chicago at an FQHC, and then at a 2-person practice, and most recently at Rush University. So I saw and cared for the same patients in 3 different settings and implemented my own MOC Part 4 all by myself when I was in private practice in a 2-person here on the west side of Chicago. And it was actually easier to do. My work, I met Dr. Sinsky when we were on the board of directors of the ABIM, and we just both love, and it gives us great joy to spend time with patients. And the regulations, the burdens are so great now, especially post-pandemic, that the opportunity to spend quality time with our patients is just being nibbled away at. And this is what gives most of us great pleasure and joy and called us to this work. So for all of us, I think saving time so that we can do more meaningful work is key. And that's my work that Dr. Christine Sinsky, who many of you know, leads at the AMA. It's all about having time to do work that requires an MD or a DO, and not doing work, unnecessary work, that could be done by another member of the team, or doesn't add quality at all, or any value to the patient or the physician's work. So our work at the AMA is about saving time so that we can get back to doctoring. And we think that almost half the day is spent doing unnecessary work, or work that does not need an MD or a DO. So I'm going to show you, next slide, please. We put some highlights together of what many of you may be familiar with, which is Steps Forward, which is open access, don't need to be an AMA member, don't even need to give us an email. We have 70 toolkits over the past 6 years and 1.4 unique users, many of whom, including the physician assistants, now I think of physician associates, have used these, and they're on their website as well. This playbook is, again, open access and highlights how we can get back to doctoring. And as you can see, as I've circled there on the left, the first thing to do is to get rid of unnecessary work. If you find the word stupid offensive, which some of us do, this is the work that Dr. Melinda Ashton did in the New England Journal, first wrote about, a doctor from Hawaii. Some people call it getting rid of waste or grow. But there's a tremendous amount of work we can do that is unnecessary. There's work we can do to get rid of the unnecessary burden. And with Tina's encouragement and ABMS's encouragement, we turn some of those opportunities into a activity in MOC Part 4. So when I was ACP governor, I would meet with people around Illinois. We have 17 residency programs here in so many hospitals. The chair of medicine would say, I can't ask my docs to do one more thing until I take something off their plate. And the fact that we can do something to decrease the work and save time and still qualify for MOC Part 4 was pivotal and critical. And it was with Tina's encouragement that we did that. In the Saving Time Playbook and in the toolkit, next slide, please, is a de-implementation checklist. This is a 2-pager. Again, it's free, it's downloadable, it's been reviewed by Joint Commission. Things like using verbal orders in a non-high acute setting. And so there's lots of downloadables that you can use, and any of these could be used as a tool to implement that qualifies for MOC Part 4. And I'm going to show you 2 slides, and then I'm going to end and hope there's lots of questions. But this was so easy to do with the folks, Dr. Jody Abbott at the AMA. Next slide, please. I took a template that is live now from on prediabetes, but I adapted it to our work. So this is just an example. It took me about an hour to change it into what I thought would be useful, not knowing if this would qualify. And Tina and the folks at the AMA were thrilled. So here is an example of your baseline measurement. You could take 10 days in the past year, it could be 10 days in the past month, and count the number of messages that are unnecessary, such as copied charts, thank you notes, normal labs, whatever, and just pick one of those, not all of them, and then do an intervention, whether that's meeting with the CMIO, whether in Epic, actually, you have total control over it. I can go into a patient chart, my patient, and I can turn off notifications, takes about 10 seconds, and these are turning off notifications of tests that another doctor ordered. Now, if I refer a patient to my cardiologist colleague or my pulmonologist, I trust that they're going to do a great job. I do not need to see in my inbox the tests that they ordered. I will review them, just before I see the patient, but I don't need those to come into my inbox. So that's just a simple intervention. You do that, and then for the baseline, you see you just calculate or count up the messages in 10 days that are unnecessary, whether it's copy charts or whatever you want. Then look at a variety of tools, one being the Saving Time Playbook, another being the Taming the EHR Playbook or a toolkit. And then, next slide. As short as 10 to 30 days later, you look at 10 days since your intervention and do the same thing. Count the number of messages that were unnecessary. And hopefully you would see at baseline that there were maybe 200 over 10 days or 20 a day. And maybe at follow-up, it went down to 10. Now we know you don't even have to, it could go up. You just have to be doing a baseline and follow up and see what worked and what didn't. In this situation, as an example, we decreased the messages from 20 to 10. And again, this whole cycle could be completed in as brief as less than 2 weeks. And the last slide, next slide, please, I'll end with, which is just a picture of the Getting Rid of Stupid Stuff toolkit, which does a deeper dive into how to do this, and suggestions of things that you could stop doing that are unnecessary and don't add value. And the bottom line is, instead of adding more work to our diplomats, we're helping them take work away, which I know is what we all need and our colleagues need because of the staffing shortage, COVID, the incivility out there. We really need to take something off their plate. And this is a wonderful opportunity to do that. So I'll send it back over to Tina, and thank you for letting me share what we're doing over at the AMA. Oh, and let me just say that you could use these actual toolkits that the AMA has and these actual examples. We have them for pre-visit planning and pre-visit labs and annual prescription renewal for chronic meds. They're not live quite yet, but you could just take what we already have at no cost to you and use them yourself. I'll hand it back to you, Tina.
Thank you so much, Marie. And thank you for really putting an exclamation point at the end of the sentence that goes something like, wow, I really love this community and how much people share. Thank you for that. And I will be making sure that all of the resources that have been shared by Marie and anything that Jill will share, you guys will receive after the webinar, in addition to a link to the recording and the slides. So the things that Marie is talking about, like she says, are available. We'll provide you some links. We have some PDFs that we can give you. And towards the end of the webinar, we'll also be sharing contact information such that if you have any additional questions that you think about after the webinar, you can get a hold of Marie or Jill. With that, please feel free to be using the chat, and I apologize for not saying that in the beginning. We will transition over to Miss Jill Hines-Nesvold from the American Lung Association, and Jill is going to talk about an initiative that has been going on there and their portfolio program. And Jill, I hand it over to you.
Great, thanks, Tina. One of the things that just struck me is Dr. Brown had mentioned that her portfolio program talks about pre-visit planning and medication refills. And that's a really nice tie-in to whether a very small part, but part of our portfolio program too. And so sometimes you'll see an overlap, and so that just validates that this is really good quality stuff we're doing. And I'll highlight those as I move forward with my comments. But hi, I'm Jill Hines. I'm National Senior Director with the American Lung Association. So I oversee health systems improvement and indoor air quality for the American Lung Association. Just a little bit of where this fits. The American Lung Association, we have three broad areas of our mission: research, advocacy, and what we term health promotion. And so all the wonderful things we do for people that breathe. Within health promotion, we have 5 broad areas. And one of the areas is what I'm responsible for nationwide, our health systems improvement and indoor air quality. 2 very different things, but yet there's really a strong relationship, knowing that indoor air quality impacts everyone with lungs, not just those individuals who already have a lung disease. But before I turn it to the next slide, here's my email address. So if you're interested in reaching out to me with questions, because part of my presentation today is an invitation to any of your practices who might find our Enhancing Care for Children with Asthma program a nice fit for you. So that invitation is there. You also will see a landing page here at lung.org/enhancing care. So feel free to look at more information there. Our portfolio program really is used as an icing on the cake, or an incentive, if you will, for providers, physicians who are participating in our quality improvement program. So if you want to move to the next slide, our Enhancing Care for Children with Asthma program is a little bit of a misnomer. We have been around for around 15 years. And so we started with caring for children with asthma. We really work across the lifespan now, and have for the last about 8 to 12 years, but we have become such a recognized, nationally known program by a number of the federal organizations. It's a little late for us to change our name now. But really what we are is, as I mentioned, nationally recognized evidence-based quality improvement program to ensure that providers are implementing guidelines-based care and clinics can provide comprehensive self-management education. We've been able to prove that we can reduce asthma-related emergency department visits and hospitalizations, as well as providing a cost savings to the healthcare system. I'll cover this in just a little bit. We have worked with 450 clinics across 15 states, and these clinics are in all shapes and sizes: urban, rural, suburban, clinics that have 1 provider, clinics that have 30 physicians that work in them, residency programs, clinics that speak English, clinics that speak Spanish, clinics that speak 78 different languages, also clinics within the Indian Health Service. So I think that just goes to show that we have a quality improvement framework that works with the culture and the style of the clinic. And it's not a cookie cutter approach forcing clinics into it. Rather, it's a flexible model for the clinics to follow. Next slide, please. So a little bit about the benefits of partnering with the Lung Association around our quality improvement programs is it helps build the capacity of the clinics. It sustains changes to the healthcare system. We've been able to prove that. We've been able to demonstrate a measurable impact in high-risk diverse patients, providing statistically significant outcomes on healthcare utilization, as well as a return on investment. And one of the great incentives we're able to provide, in addition to CME and CE credits for trainings, is maintenance of certification credits for those physicians who participate with us. Next slide. So how do we do this? And we do this by kind of 4 broad areas. We provide technical assistance to all of our partner clinics. We provide training as well. And the training is for all disciplines within the clinic, and it's tailored to the nurses, MAs, medical assistants, physicians, pharmacists, and the like. So it's very tailored. Some of them are billed and they come to us, other ones that we can provide virtually one-on-one to the clinic, or now we're getting back to everything we're actually doing most of our trainings in person. So excited about that. We do have this quality improvement framework that's proven. Clinics work through this framework over 11 to 12 months. So it's a large process that we have set forth for them. And along the quality improvement process, we do evaluate. So then the clinics know where they're starting from and they can see the progress that they're making. Next slide, please. A little bit more about this, one of the comments I always make is that quality improvement initiatives must deliver improved outcomes and health savings. It can't just be about a good idea and let's try something for a little while. We must have the evidence that we can improve outcomes, save money, and this initiative has been proven to do both. So now I'll talk a little bit about that on the next slides. So we have been fortunate to be able to publish our findings 3 different times. The first one was in May of 18 in the Journal of Asthma, where we looked at 65 primary care clinics across 4 different states and looking at how the guidelines-based care was being implemented from before the QI initiative to at the end of the 12-month formal QI initiative and then 6 months later. And again, we had statistically significant improvements in each of those 6 clinic indicators. We also, right as the pandemic was starting in March of 2020, we were able to be published again using administrative claims from Blue Cross and Blue Shield. We were able to look at 15 of our partner clinics across 4 states and look at the impact on health care utilization for those individuals with asthma who were receiving care at a partner clinic. And what we found is there was this really wonderful reduction of 38% in ED visits and 47% in asthma-related hospitalizations. You even them out, it's about 42% reduction in healthcare utilization. But that wasn't enough, so we did a 3rd publication on the next slide. And what we were able to demonstrate here, and this came out in May of 2020, is our return on investment. What we found using the same Blue Cross and Blue Shield claims data for these 1,900 individuals was that for every dollar invested in the Quality Improvement Initiative by the American Lung Association, Blue Cross and Blue Shield saved $2.40. So a really nice return on investment. If you look at it over total asthma costs, within the first year of the QI initiative, they saw a reduction of 57% in those annual healthcare costs. So I jokingly say that we provided a really nice coupon through our quality improvement initiative. So the next and final slide really outlines how this is actualized in a clinic. And if you will, if you're kind of a visual learner like I am, you can look up in the project start in the right-hand corner is where we recruit clinics or they come to us finding that they need assistance in their asthma care across the lifespan. And we develop a partnership with those clinics and what we call recruit them. At the point of launch, we conduct a baseline chart audit with them. It takes about 2.5 hours, our clinics report, and that's really the launch. And then over the next year, whether we're doing it in person or virtual, we meet with the clinics in a learning collaborative cohort style a number of times, and we work through a process of components. I had mentioned excuse me, there is a little bit of overlap with what Dr. Brown was talking about. One of our components we work through is pre-visit planning for individuals with asthma, as well as refills of medications and ensuring we get appropriate amount of refills, but not an excess, which would indicate poor disease control. Between each of these formal learning collaborative cohort meetings, we provide technical assistance to clinics on a monthly basis. We provide a whole host of training opportunities for the different disciplines within the clinic. We have patient education materials available for the clinics to use. And then we evaluate not only the data collection at baseline, we do it again at 12 months and then 6 months later at 18 months. One of the things we were able to do is go back and look at 24 of our partner clinics from 6-7 years ago and see how long their quality improvement measures lasted. And what we were able to demonstrate is that quality lasted through this particular program out 5 years. And so we're working on the publication of that, but it really is a testament to how well the clinics do that this model works, and then the quality is more than just a one and busy work and done, but rather it makes sustainable changes to the way that clinics work smarter, more effectively, which in turn makes an impact on the health, the life, and the costs of the patients they're serving. So as I come to the end of my slides, and maybe we can move on to the next slide, I'll just wrap up to say that the portfolio, the way we implement it, the portfolio is an accumulation of the entire quality improvement model. It really is one of the incentives for physicians who participate in the QI initiative, that they can earn 2025 maintenance of certification credits for their meaningful participation. I mentioned in the beginning that it was also a little bit of a marketing ploy, so please keep my email handy. So if this is a program that you think your clinic might be interested in, we are currently inviting clinics to partner with us for August, September, maybe even into an October launch. And so we would love to see if this is a fit for your clinic as well. Back to you, Tina.
Well, thank you, ma'am. And that is great. I did not know that. So again, you guys who are attending right now, and anybody who is receiving the recording later, we will include some information regarding Jill's invitation with that communication. So thank you for that. So I'm looking at the chat, checking to see if we've got any questions that have been posted so far. There are not any there so far. I welcome anybody who has questions for either Marie or Jill or both to either raise your hand or to post something in the chat. And in the meanwhile, while you're kind of chewing on what has been shared so far, I actually just want to point out a couple of things, and then I might actually have a couple of questions as well. One thing I want to go back to is something that Marie mentioned when she was talking about participants looking at baseline and follow-up metrics. And I just wanted to call attention back to the fact that a participant, a diplomate, can receive credit for participating in a performance improvement or a QI type activity, even if they don't improve. They can actually, their performance could get worse, God forbid, but it happens, and we know it happens, and they would still get credit because they're engaging in the process. So thank you for mentioning that, Marie. And I just want to make sure that I do call attention to it, because that's a really important thing for people to remember. And I guess what I would like to do while people are kind of thinking about what's been talked about is ask the two of you, Jill and Marie, now that you have, we've spent some time together prepping for this call, and you've now heard each other a few times, kind of share what your programs have been like. Can you guys take a moment to really just share your thoughts about how your programs are maybe the same and where you think there are differences, and just kind of call those out so that people can understand or really get a better picture of the fact that this program can be implemented in a multitude of different ways rather, and have it work for you. And Jill, you're the closest to me on the screen, so I'll ask you to respond first.
I'd be happy to. I think there's some similarities, and then there's some big differences as well. Some of the similarities that occur to me is both are helping providers work smarter, not harder. Right. And so let's think about our workflow design and how we can be effective and get rid of anything that's not evidence-based, that's not going to improve patient care. So kind of get rid of the noise, so to speak. There also are some similarities, as Dr. Brown had mentioned, around her program touches on, or some depth of pre-visit planning, medication refills. Those are things that we talk about, but ours are disease specific. But certainly tools that you learn in quality improvement just in one disease are applicable and generalizable to others as well. I think one of the big differences that occurs to me is maybe the length and the longevity of the programs. Our quality improvement program is designed to be clinic-wide, not provider by provider. And they're also, it's bigger. right? And we're engaging with clinics for a year because we know that this is a quality improvement at the clinic level is a marathon. It's not a sprint. And so sometimes there might be 3-4 weeks that go by the way you can't focus on asthma quality improvement. So we need enough time to work through the evidence-based framework without trying to swallow the whole apple basket at once. And so ours is spread over a year, where my perception, and I'll leave it to Dr. Brown, is that her program works maybe a little bit more provider by provider, and it's maybe a little shorter in duration. But I may be wrong, and so I'll pass it to Dr. Brown to respond to the question as well.
Very good insights in the similarities and the differences. And the short duration was really a big issue. I will say that at the AMA and when I was on the ABIM board, we know that the diplomats are they're busy, right? 2 hours of work, 80 to 100 hours a week, 2 hours of work on the EHR at home. And then all of a sudden maintenance of, your certification is going to expire. The folks my colleagues at the AMA shared that about 2 weeks before the expiration date is about when some of the diplomats say, oh my gosh, I've got to do something quickly. And I too thought, well, you couldn't do this in a short period of time. But the more I thought about it, and the more Tina and I and our colleagues at the AMA thought about it, is yes, you can. You can implement a pre-visit labs, like, okay, for all our chronic disease management, we want our patients to have their A1C and their BMP on the day of the visit. So let's do pre-visit labs. Again, to your point, Jill, you don't want to swallow the ocean. You might choose, your intervention may be very, very simple, such as the last 3 patients of the day, the first 3 patients of the day for 1 week. See if we can do pre-visit planning for 2 or 3 patients a day. Because we start out, we get behind very quickly, or we're tired at the end of the day. Those last 3 patients just exhaust us, and we take all that work home. And if you try to do that, and then you look back a week and say, gee, it didn't work. Why didn't it work? Oh, we didn't give the MA time to do pre-visit labs. Or I ordered the labs for today, and I told the patient to get them a week before their next visit in 3 months. But when they checked out at the reception desk, my receptionist, who we didn't involve, said, oh, that's a mistake. You should only have 1 lab test.
Mm-hmm.
And that's the iterative nature. So it may not improve a week later, but you're like, oh, why didn't it happen? Oh, we forgot to tell Sheila at the front desk that this is for today. It's the first time you do it, it's going to take more time. And this is for a week before your next visit. Mm-hmm. Or the patients are confused. So maybe, and it doesn't get done. So maybe you look and see that we need to hand out a little flyer for the patient. And that could be a PDSA cycle very, very quickly. Now, annual prescription renewal, if you begin that today, when you usually are writing 90 with 1 refill for blood pressure or diabetes medicine, you're not going to see any impact if you go from 90 times 1 to 90 times 4. You couldn't possibly see an impact until 6 months. And if you've got to get your certification done. But people are doing that. We have a Mentoring for Impact program that I lead to have these sorts of conversations. And people want to do that. Why shouldn't they get credit for it? So it's not adding on more to do. They're already doing it. And we know that if you do 90 times 4, call me no more, similar to your medication adherence with asthma, you save an hour to a day. And you don't hire a refill nurse. That nurse is then doing nursing work instead of sitting on the phone talking to every retail pharmacy in the Chicagoland area. So it could be a week, it could be 6 months. The point is, try something that's going to save you time. See if it works. If it doesn't, find out why. And it's an iterative process. And that's what I learned when I reluctantly did MOC Part 4, and it saved me hours a day in my little 2-person practice. It took, the learning curve was I couldn't just do it, right? I didn't top down. I had to get the whole team on board. Everybody needed to understand why we were doing it. We talk about WIFM, what's in it for me, so what's in it for the receptionist, what's in it for the MA. Is the doctor going to be on time? Does everybody get off, leave when the lights out, everybody goes home and doesn't take work home? So you have to answer all these questions, but we're already doing the work, so why not get credit for it? And it's meaningful. Again, to your point, Jill, it's asthma, but the family practice and the internist, there's 1,600 guidelines on an average of a 17-minute visit. And I think it's important, we know that it's important for the diplomat to choose what they want to work on.
Mm-hmm.
Right? It may be asthma, it may be diabetes, it may be hypertension, it may be choosing to intervene with a standing order that every patient with type 2 diabetes automatically is sent to a diabetes educator. That's a great intervention. It could be that you have an opioid problem on your panel. The standing order could be every single patient who's on has non-cancer pain is automatically referred to a physical therapist. That's a great intervention that's going to improve the quality, and it's going to take time off and lower the burden of the physician. So I think personalizing it and embracing that the diplomat knows what's meaningful for them and what would help them and their patients, as well as save time, is the approach that we took, which was a change from years ago. Years ago, when we first tried to use Steps Forward as the intervention, our internal AMA had more stringent requirements than the ABIM did. Instead of requiring 1 cycle, they required 2. So they were over-interpreting the rules of the ABMS and the ABIM. And we said, well, why are we doing this to ourselves? So often we are shooting ourselves in the foot, and we have to stop doing that.
Yes, Marie. And I think that's one of the best things. One of the things I like the most about the approach that you have with these toolkits is that you have kind of figured out what your process is based on what your education is that you guys have. You sort of figured out what your process is, where to kind of overlay or insert a step, like pause and do this real quick, because if you want credit, you have to record, your baseline, which you went through that great and easy. It's simple slide. It's got the great direct instructions. They're simple. You just record it right on the screen. And I think that the way you guys are able to take kind of this process and this structure, you'll now be able to kind of lay it over various different topics that you guys are implementing. And I really appreciate that about the approach that you guys take. And Jill, with you, if I were still on the other side of this fence, I would be operating in that fashion. When I started the portfolio program at the University of Wisconsin, it was big. I had a committee with lots of physician champions, and I was doing all kinds of things. And I wanted, for the organization, the national organization level for the UW. So it was different than an individual going online and finding this toolkit that's available and being able to just implement, let me remove that word, being able to implement changes into their own practice. And that's different. You guys are working at a national level. You're working to really change culture. And my question for you then, Jill, is, so if you guys have this for the asthma, I'm looking at your asthma quality improvement mapping. I love this slide so much. And I'm just thinking, are there other topic areas? Are you going to apply this same framework to anything else?
We use the framework for COPD as well.
Okay.
Or what is no longer called the asthma COPD overlap syndrome. It was called that from 2009 to 2020, and then now they've decided not to use the term. But we know that about 25% of people with COPD also have asthma, so that's a big chunk. And so for clinics that engage with us around quality improvement for COPD or the dual diagnosis, we use the same quality improvement process framework. We have not yet applied for and secured maintenance of certification credits for those.
Gotcha. Okay. Marie, same question kind of to you. So we know you have the steps forward and the pieces that are kind of in that. I don't want to get too deep in the weeds with AMA lingo, but I know I think that's part of the Ed Hub. Is that right? You guys have this. Okay. So can you just talk a little bit about the Ed Hub and what other pieces might be there, whether you've been part of conversation thinking about credit for those things, or if you just think there might be other resources that would be good for the folks that are on the call?
Yeah, the Ed Hub is the educational, CME program. The Steps Forward is actually, some of them are housed on the Ed Hub. Some are housed on a separate platform. They're easy to get to both because our intention of Steps Forward was to make it so accessible that you didn't need, it wasn't for CME. It was really to change your practice. These are practical, actionable.
Mhm.
This is not why we do it. This is how we do it. And it works here, and we have lots of success stories. People like the opportunity to share their success stories. And many of the success stories are federally qualified health centers, really under-resourced, where they did something that they were going to do anyway because they have to. And in this day and age, with the crisis really in healthcare post-pandemic and the staffing shortage, we can't ask our diplomats to do one more thing. We have got to work in the background and take something off their plate. Because I was just talking in the mentoring program to a group today, 5 physicians in a Department of Internal Medicine left. They just can't take it anymore. They can't work 80 hours a week. So we really, you may have tried things in the past, those on the call, and hit a barrier. I would say that everybody's listening a little bit more intently now, especially the C-suite and administration, because of the staffing shortage and the recognition that physicians are burning out. Talk about the ROI, Jill. We have again, the 4th part of our playbook is how do you sell it to leadership? We have to talk about ROI for a doctor. The ROI is a release of information. We don't talk that way, return on investment, but our audience does speak that way. So there's tools to how to present the same information. It's all about having time to care for our patients in a way that's meaningful to our audience. And our audience may be the compliance officer, it may be risk management, it may be revenue cycle, it may be the CMIO, but tailoring the message is important. And the Ed Hub has a lot of opportunities with lots of CME. There is a quiz that you need to take, and you need to put in an email because we have to track you, and it asks you for your ABIM number. I'm an internist, and whether you want it sent directly to ABMS, and ABMS, I think, Tina, you can tell me the logistics, sends it to ABIM. The quiz is as simple as, did this have an impact in your practice? You do need to write a sentence like after your baseline, what did you learn? It could be as simple as, I'm doing a lot of unnecessary clicks to get rid of things in my inbox. And it adds up. And when you add it up, it's 40 minutes a day. And it's frustrating. We think 3 clicks here, 5 clicks there. It's just a second or 2 or 3. But when it's 1,500 clicks a day, which one organization found, it's an hour per provider. Well, that's an extra day, right? Or that's an extra hour with their family at home, or more time with the patients. So there's a couple of steps. And then after you do your follow-up, what did you learn, right? And you could say, as you said, Tina, well, if we didn't improve because we found out the receptionist was throwing away one of the pre-visit lab forms, and now we're going to do it again. So, adopt, adapt, abandon, whatever. And then I think it was pretty simple. I think the simplicity of it is what I like about it. again, in the mentoring program that we run at the AMA, we're doing this anyway. So to get people the incentive to participate at the local level, we worked with an organization here in Chicago, and I was invited to be part of their every 2-week practice efficiency committee, which they organized, but I was a subject matter expert. They were doing it anyway, but what a wonderful incentive. We could say, the work you're doing also qualifies for all of you to do MOC.
Yes.
Here's how simple it is. Like, oh,
yes,
they're doing it anyway because they know they have to get things off the doctor's desk, and not just hire more people to triage the messages there. We have to stop the messages from coming in the inbox. So I think that's there's a couple of it's a little bit more involved at the Ed Hub because we need to track you so that you can go to the board so you get the credit for it. But it's pretty simple.
Dr. Brown,
go ahead, Jill.
I'm sorry. You mentioned a couple things I thought were key. Is a lot of this is not teaching somebody something new all the time, but it's having an organized framework in a way to approach it and work smarter and more efficiently. And if you just told somebody, go do asthma better, or go do the busy work of the job of being a physician, go do it better, they're going to throw up their hands and not necessarily know where to start and how to approach it. But both of our portfolio programs sound like an organized, common sense of format to guide somebody through the process, to think about how to work better, work more efficiently, work smarter, with the end result of better patient care.
Yep,
and that's we're both doing it different. Ours is bigger because we're dealing with a comprehensive disease state, but neither doesn't make either one more better or more important, but we both approach it in the same way. Common sense, how do we be more effective, more efficient? And what can somebody else on the care team do? Not everything needs to be done by the provider. There's other people with skills and knowledge on the care team that can do pieces of the work to ensure quality care.
Right. And I'll add, given that we're we're in the pandemic, but becoming an endemic, you can do for pre-visit planning, you can choose a vaccine, right? Mm-hmm. And when we talk about that, we have a toolkit on a team-based approach to vaccination. We encourage you not to choose flu or COVID, but rather choose one that is going to last for 10 years, like Tdap, right? Because you're going to learn a lot from that. And the intervention could be something as simple as someone, it could be a non-clinical person, identifies whether they've had a Tdap, tetanus, and if they didn't, you pull out a vaccine information statement and hand it to the receptionist. And upon check-in, the receptionist hands them the VIS for whatever vaccine you choose to study. That process will have a lot of challenges, but the patient is beginning to be engaged and informed in the waiting room. And that's written at a 3rd and 4th, 5th grade level. So by the time they come back, the conversation is not new. The MA can say, so I see you're due for your Tdap. What, any questions, or can I just set that up and have a standing order so it gets done? So it really saves a lot of time, and there's lots of toolkits to do something that's meaningful to you and your diplomats. Like for the Lung Association, of course, it's asthma and COPD.
That's great. Thank you. You guys are, I can't keep up. I'm having so many different thoughts about everything that you guys are talking about that I'm having a hard time even keeping up, but I can tell you that I'm excited about some of the things that you guys are thinking. And I just want to share with the folks on the phone. Some of you already know this, but the conversation today really does highlight one of my personal favorite things about this community. And that is, like I said earlier, everybody is very willing to share. There are a couple of folks on the phone who I know are portfolio program sponsors, and they came in to hear what other sponsors are doing that are kind of like them in terms of like organizations and stuff. And it's just, it's people here are very open. Like Marie said, she's willing to share kind of the framework for how they're going to be approving credit for these toolkits going forward. And I know that she wouldn't be alone in that. Any of the tools and resources that people in this community have, they're always willing to share. Speaking of which, after the call today, you guys will receive a bunch of information. One of them is going to be a document about credit. And I'm bringing this up now because somebody asked about a credit question. Marie, you mentioned that I think it was when you were talking about when you were working with or at the ABIM, and you mentioned that you were providing CME credits at the level of 20 or 25 credits. Pardon me, I'm not sure if I captured that correctly, but can you just talk a little bit about do you recall that part of the conversation?
I think Jill mentioned credits because
I apologize. Jill, do you remember that part of the conversation?
I did mention credits. I mentioned that our trainings provide CME and CEU credits as well as the maintenance of certification credits. Is that what you were referring to, Tina?
Gotcha. Yes. And I think this might be somebody that I'll connect you with after the fact, but I do want to make sure that folks on the phone know, with regard to this table that you'll receive, it'll show you the 18 different ABMS member boards that work with the portfolio program. And it'll show you, we call it the credit translation table, because it'll really show what each individual diplomate will receive once a QI activity or a completion rather is entered on their behalf through the portfolio program. And in some cases that's called points, and in some cases it's called credits, and in some cases it just says check mark, you did that. The quality improvement section has been done. So I'll share that with you guys as well. I'm looking at the time. We have a couple of minutes to the hour, and I just want to make sure that we are giving the folks who joined the call any time to ask any additional questions. We're getting some thank yous to you guys, Marie and Jill. So do you guys, before we go, do you guys have any last minute things you would like to share with the people on the call?
Sure. Just like thank you for your time. And all of the toolkits, the 70 plus toolkits and the playbooks are completely open access. You can house them on your own website for those people who are representatives of another organization. Many organizations already do that. We encourage it, and anything we can do to facilitate. My email is there, marie.brown@ama-assn.org, including talking with you about the Mentoring for Impact program or the Joint Medicine Award and all of that. But it can be simple, it can be kind of fun, and it can save time. And I would encourage you to look at time-saving maintenance of certification opportunities, because there's a lot out there. Jill?
Just thank you for inviting us. Thank you for allowing me to share some of the quality improvement work we have going on at the American Lung Association, and inviting clinical practices that might have an interest or not sure you have an interest, but would like to learn more. Please reach out to me. We'd be happy to talk to you about whether this is appropriate and a fit for you. We'd love to join you, and a friendly note that our quality improvement program partnerships are at no charge to the clinic, so free is good. Tina, thanks for inviting me today.
Yes, ma'am. Thank you, Jill. And thank you, Marie. And thank you to everyone who was able to join us today. We really appreciate you guys taking the time to just step away from whatever it was you were doing and kind of join us for this conversation. Look forward to sending you some follow-up email information, including a lot of the resources that were shared today. And please let us know if you have any questions going forward. We thank you for your time today and have a wonderful rest of the afternoon. Bye, everyone.
Bye.